And now I have two small questions to Dr. Krishnan. I hope Professor in future. There was a question from the auditorium, and this was a question from me as well. Can a fetus with Down syndrome look absolutely normal? I think the problem is that once Professor Shawi, not once, he told us that everyone can miss a fetus with Down syndrome, but I think he isn't quite strict to the truth. I think he knows more than that, but we all feel that, okay, it's nothing wrong to miss a Down syndrome baby. What's your opinion on this problem?
I think unlike trisomy 18 and 13, where you have very clear clinical indications, it is quite possible that in your busy practice you might occasionally miss a case of Down syndrome simply because the ultrasound finds are not as robust as the trisomy 18 or 13. There could be very subtle findings. Sometimes if you look at the face could look absolutely normal. I remember a presentation of Professor Benoit where he showed 20 fetuses with Down syndrome, and he asked us to pick out which of these were Down syndrome from the face profile views, and we could not. So he was saying that, the ones that we thought were normal was Down, and the ones that we thought were Downs were completely normal. So it's quite difficult to make out Down syndrome from the facial profile. But having said that, if you follow a very robust screening protocol right in the first trimester, you look at all the markers, you do your first trimester combined test or your NIPT, whichever is your protocol in your part of the world, and you do an extended anomaly level 2 anomaly scan in the second trimester. I think fairly large amount of Down syndrome cases that in today's day and age, and with the kind of ultrasound that we do, should end up getting picked either in the first trimester by virtue of your screening or in the second trimester by one of the soft markers. So it's not that you might every day miss a Down syndrome, but occasionally in your practice, maybe in the last 10, 15 years that we have been practicing, I've probably missed a couple of cases which had absolutely nothing on scan. We went back and audited our images. We went back and revisited the screening test. The screening test showed a borderline 1,001 and 1,200 kind of risk. Absolutely nothing on scan. The patient was the doctor herself. Yes, so it can happen, but our efforts should be diverted towards minimizing the number of cases that we miss. And quite unlike trisomy 18, 13, yes, Down syndrome cases could occasionally be missed, but we should strive in every possible way to minimize those numbers, and that will be a good hallmark, good measure of your practice as well.
I would read the answer of Professor Kalash. He says, sure, but in my opinion, and from what I and others observed, the face will always be abnormal. Subtle changes, but abnormal. So this is the answer to the question.
No, I agree. The face will definitely be abnormal, but how good are we in picking up those abnormalities is that will depend on how good you are with your scans and what level of scanning you do and how much time you can devote to the anomaly scan. So I think it's more of not just looking at the face, it's more of following a definite protocol right from the first trimester, get your basics right, and then you minimize the number of Down syndromes that you're going to miss in practice.
Well, and I think with the more we work, the more experience we have, the more we can pick up these subtle features on echograms. The other question is about trisomies 18 and 13. Although they have very marked ultrasound changes, but sometimes there are mild cases where there are not so many clues. And unfortunately, here in Ukraine, 1 or 2 or 3 cases per year, we have missed cases. And very sadly, these babies would have IUGR and they would be kind of saved during by C-section. And this is absolutely it's impossible. It's very awful. Do you come across such cases in your practice?
Yes, we do. Occasionally, you get the late referral for a possible missed trisomy, and that's probably because the anatomy scan wasn't done the way it should have been, or probably the sonographer was not very aware of the markers that could point to a trisomy 18 or 13. And invariably, most of them would have some amount of growth restriction. If you look at the hands, as I said, the hands give you the clue to the underlying chromosomal abnormality. So, I guess you would have seen the paper that I quoted. So they say that the editorial that I quoted, it says it's completely ultrasound diagnosis. In today's day and age of ultrasound, you should not really miss out on trisomy 18. But having said that, not all sonographers practice the same way. They don't have the time or the resources to practice the level of scanning that fetal medicine specialists might do. So yes, it is not impossible to miss trisomy 18-13, particularly if you're not aware of the abnormalities and you really don't look for them. Because as I said during the lecture, some of these are very subtle findings, particularly the hand findings, the foot findings. You might just pass it off as a growth restricted baby with a CP cyst. The strawberry skull may go undetected. The clenched fist might go undetected. The rocker bottom feet might go undetected. So yes, these are subtle anomalies, but the fact is all trisomy 18s or 13s for that matter would present with anomalies. So it depends on how good you're at picking them that lead to your improved or not so good detection rate.
I was very glad to find in a last FIGO guideline devoted to IUGR that they stress few times on the importance of genetic evaluation in cases of sub-early IUGR. I mean, it's very important. If a doctor cannot pick up these small signs, he can always measure the baby, and IUGR is rather a simple diagnosis. There is one last question. Your patient would often reject termination of pregnancy in cases of these lethal trisomies, and how would the obstetrician plan the delivery in such cases? Do you have such information?
Thankfully for us in our part of the world, we have this recent amendment to our Abortion Act, which says even if it's beyond 24 weeks, you pick up a lethal trisomy, you could still approach the medical board and the medical board could approve termination, irrespective of how late the pregnancy goes. So that is a very recent change that has come about in India. So after that, I think most of these lethal trisomies do get terminated. And it's very rare to find a couple who would come forward and say, we would want to continue, especially with the trisomy 18 and 13. Trisomy 21, of course, there are patients or there are parents who would definitely choose to continue the pregnancy. They go through self-help groups. They do a lot of research on the internet, and they come back and say, okay, this doesn't look as bad as we thought it was, so let's continue the pregnancy. But trisomy 18 and 13, when you really sit across the counseling table, take your time and explain to them that these are lethal anomalies with very little reported survival rates after birth, most of them tend to agree to a termination of pregnancy. That's been my experience.
Okay, thank you very much. Thank you very much, Dr. Krishnan, for joining us today. It was a pleasure to have you here. And I hope you liked our seminar as well and will be able to join us to watch us at the later time of the day.
Sure. Thank you. Thanks.
Dear colleagues, unfortunately, we will not have time for a proper lunch. You will have to grab a cup of coffee or a sandwich, and after a very, very short pause, we will return to our learning. Thank you.